So we have 30 minutes to do this discussion, and we have 2 cases, so we have time. Perhaps I can show the first one, Bertrand. So we have a young lady, 20 years old. She had ACL reconstruction a few years ago. She has pain and effusion. And I show you the clinical examination. So you can see the Lachman with probably a delayed hard endpoint. The pivot shift is positive, not huge, but there is some pivot shift. There is some hyperextension. I did not find medial or lateral laxity. And the anterior drawer at 90 degrees. On the other knee, there is no history of ACL. Perhaps a slight positive pivot shift on the contralateral knee. You can see the hyperextension. And no laxity. And no global laxity, you know.
Camilo, any suggestion?
This patient, for me, has a lot of risk factors. 20 years old, so it's a young patient with hyperlaxity. So I think these cases are very difficult to treat. If at the first time, probably I would do something more than a simple ACL reconstruction for this case. And of course, now I think we need to study, associate lesions, but probably it's a candidate for ACL reconstruction with at least S-articularplasty and maybe, depending on bone morphology, other associated procedures.
Do you check for elbow laxity, wrist laxity?
We always check the Baton score for all patients. I don't really believe Baton score is the best way to measure that. We recently published that probably for ACL, the most important tool is to evaluate only knee hyperextension. And we showed that if you have more than 6 degrees of hyperextension, you have a 14 times more chance to re-rupture the graft. So we check Baton score, but I normally only rely on knee hyperextension.
JC, in primary ACL for this typical case of patient, what would you propose? Yeah. If it's primary.
Yeah, to me it's mandatory to, before giving an opinion, to get the full cassette X-ray, including AP, lateral, choose view, everything. Then the MRI and then a CT scan just to check the dilation, possible dilation of tunnels. And then I would probably anticipate, as Camilo said, that one thing is knee hyperextension, another thing is hyperextension of the knee in the context of general laxity. I think both are important. But probably for this lady, if it's active, I guess it's really active, 20 years old, I would probably go for a patellar tendon reconstruction plus lateral tenodesis, plus if it's any kind of increase in the posterior lobe, deflection osteotomy as well at the same time.
And Bob, in US, for this patient on primary setting, what would you propose?
Essentially the same. For primary, I think in this case, I would lean toward a patellar tendon autograft. I think I wouldn't recommend any, I think for me, I never address or think about addressing slope in a primary situation. I think this is more patellar tendon autograft, and I think it's open to discussion as to whether to add a lateral procedure in these cases. I think for me, when you have these increased in the setting of patellar tendon, I think when you have these risk factors, I would be likely to do that and add a lateral procedure as well, even in the primary setting with a patellar tendon in a patient with all these risk factors.
Al?
Yeah, not much really to add to what's already been said. The only thing I do look for, particularly in the revision scenario, is any evidence of external rotation laxity. So very mindful of potential anteromedial laxity, posterolateral laxity. And then looking at symmetry. So symmetry of hyperextension. Sometimes you will find they've got a slight fixed flexion deformity, which will maybe make me think that I want to do a slope correction, but equally, you know, comparing to the contralateral side, if you have increased hyperextension on the affected side compared to the contralateral, then it's again pointing to another sort of corner problem.
But in primary case, what you would propose here?
Primary case, I would randomize to BTB versus quadriceps tendon with or without tenodesis.
Do you use a brace for this kind of patient with hyperextension in a post-op pre-op protocol? And do you limit the extension?
I personally don't use braces post-op any primary reconstruction, not unless I'm doing a concomitant procedure.
Elvira, what would you propose for primary ACL?
For primary, I will have done not BTB, hamstrings. For me now is really common to do BTB and primary, but I will add extra-articular procedure. We randomize so far the patient, so maybe a LAL, maybe a LETs, depending on the randomization. But and a breast, I put a breast of my patient, especially because just they feel more safe with a breast. I'm not sure it's useful, but yeah.
David, for your primary ACL in this patient?
Pour cette patiente, j'aurais certainement pris les ischio-jambiers et associé une plastie extra-articulaire parce que effectivement là, les facteurs de risque hors anatomiques qu'on n'a pas encore vus sont qu'elle avait 16 ans, une hyperextension, une fille, tous les bons éléments pour recasser.
Stéphane, si la patiente avait un problème de collagénose, est-ce que l'allogreffe est intéressante chez ce type de patient?
Alors tout le problème en fait chez ce genre de patient, c'est que je pense qu'elle a une laxité globale. Elle a quand même un morphotype de laxité globale, et je pense que la problématique c'est de savoir quel est son niveau. L'allogreffe, le problème c'est de savoir quel est le niveau de demande du sportif derrière, parce qu'on sait très bien que quand on utilise une allogreffe, on a un risque de rupture qui est un petit peu plus important et on a une distension qui est un petit peu plus importante. Donc, je dirais qu'en première intention, de toutes les manières, chez nous, en France, on n'a pas d'indication pour les allogreffes. Par contre, après, effectivement, pour une reprise, je prendrais une allogreffe qui serait assez rigide. On a vu par exemple que le tendon quadricipital, ou quand on double les ischio-jambiers, on est relativement rigide, avec une plastie antérolatérale complémentaire. Et puis, il faudrait effectivement vérifier, comme on le disait, les tunnels, la pente et ainsi de suite. Mais sur une allogreffe en première intention, d'abord c'est pas usuel et c'est pas recommandé, et je pense que c'est pas une excellente indication, surtout en plus quand on a une laxité globale.
Elvira?
For Alan, now you're in Middle East. Do you use still BTB in Middle East?
BTB, yes. There's a lot of concern over anterior knee pain and kneeling, issues with the kneeling. I think with modern day harvest techniques, I use a 2-incision technique, bone graft patella, bone graft the tibial tuberosity. I don't think the incidence of anterior knee pain with BTB grafts is as high as what it maybe previously was. And certainly we've seen that and shown that in our cases in the Middle East, and a lot of patients can go back to praying. You do have to warn them, though, that there is a risk, certainly with any sort of paresthesia around the knee, but that can happen even with a hamstring graft, and so a lot of knee surgery will develop those sorts of issues.
I have a question for you guys. Who in this primary case would have an extra-articular reconstruction for the primary ACL? 50%, we can say, probably.
And Bertrand, everybody, do you use lateral tenodesis with fasciolata or ELL?
It's a good question. I still don't know. I would say that for this kind of very hyperlax and higher risk patient, I think I must trust. I have no data to show that, but I probably trust more the Lemaire. I think there is more constraint, and that's very important for this kind of profile. Or now I do open ILL, so it's a modification of ILL that is under the LCL.
Yeah, perhaps it's better to do better than original anatomy in this kind of patient. Any comment at this stage? So I'll show you the X-ray. This is a X-ray in a monopodal lateral and AP view. Do you have any comment? Camilo, do you see?
I think the tibial tunnel is a little posterior than I would do. And I think the femoral tunnel, it's a little anterior. I'm not sure if I'm looking properly, but so I think there are these two possible issues with the reconstruction.
Yes,
that's interesting because many years ago it was recommended in this type of patients to posteriorize a little bit the tibial tunnel so as to prevent, changing the hyperextension of the lady. That is important probably for the normal behavior. However, in this case, it's clearly a mistake because both tunnels are in the wrong position. So,
do you think the reason of failure is more the tunnel position or the hyperextension and the type of patient?
Probably both. I mean, it's both? A consequence of the mistakes plus the, status of the lady.
And in this configuration, you have a short graft, and as you are using hamstrings and the patient has hyperlaxity, probably it's possible that she didn't have like a traumatic rupture, but she got a lengthening of the graft and a failure because of that, because in these situations, it's common to see the patient in the early postoperative period to have a restriction of range of motion because of the length of the graft inside the joint.
David, un commentaire?
Moi, j'aime bien ces radios parce qu'elles disent, elles expliquent exactement pourquoi la greffe a pas fonctionné puisque les tunnels sont vraiment mal positionnés et il n'y a pas d'autres facteurs anatomiques qui semblent être pathologiques. La pente tibiale, je l'ai pas mesurée, mais elle semble pas énorme. Il n'y a pas de translation de l'appui monopodal et donc on a l'explication.
It was isolated hamstring in this patient. So, as you said, David, the slope is quite normal, 10 degrees, using the MPTS. And the translation in a monopodal view is totally zero. So this is a key point. When you do your X-ray, it's very important to check this translation. And it can give you the key that the slope is probably not the problem in this patient. And the patella looks a little bit alta, but it's not huge. Any comment on this X-ray? Yes?
David, even this lady does not reach the threshold for a deflection osteotomy, being a failure and being so young. Probably, do you consider doing an osteotomy as well in this case?
Pas du tout.
Meaning 5 degrees to left the posterior tibial slope at 5 degrees.
Pas du tout, parce que elle a pas de, pour moi, elle a pas de translation en appui monopodal, donc elle a pas de facteur pour stresser ou stretcher la greffe. Si c'était la même patiente avec une translation en appui monopodal de 7, 8, oui, je ferais quelque chose.
Même si la pente était à 9 ou 10, non?
Même si la pente était à 9 ou 10. Et même s'il y a une hyperextension.
Ouais.
For the other guy, if the slope is 10, so less than 12, and you have an anterior tibial translation, do you consider slope correction?
I think you should certainly consider it, and I think what David put up earlier on with your indications, I follow that very clearly, in that if you have increased anterior tibial translation, particularly if you've meniscus deficiency, even some posterolateral, posteromedial wear, and you want to change the contact mechanics of the joint, then doing a slope reduction will change your point loading. So I think all of those things come into your decision-making profile, but at the same time, it's I don't think you necessarily need to be too aggressive. I think sometimes you can sit up here and we could all say we could do an osteotomy in so many of these patients. And, you know, the likelihood is she just needs a really good ACL reconstruction. She never had a good ACL reconstruction in the first place. And if you use an appropriate graft and put it in the proper place with likely addition of a lateral tenodesis, she'll probably do very, very well.
So this is laxity telos side-to-side difference. It's not so big. You have 4 millimeter on right side and 8 millimeter on left side. So plus 4 millimeter. Do you use, everybody use something to assess the laxity? Camillo, what kind of device do you use?
I use the lachimeter to check. Always check the side-to-side difference. This is what I do.
What is it? When I ask, what does it do? How does it influence your decision making?
It influences more if you have less than 5 millimeters of anterior translation difference, like this case. If it was not a hyperlaxity patient, high grade, high risk patient, it's the way we use less than 5 millimeters. We consider not to operate or not to revise, or we consider just to, in some very specific cases, to add just a lateral procedure if it was not performed at first place. But I think this case that has a lot of risk factors, I would not consider doing this. I would revise the whole thing.
Bob?
I don't generally use any method to quantify the anterior translation. I think sort of along the lines of what Al was saying, I don't think knowing the side-to-side difference here is going to change what I'm going to do. So for me, it doesn't really impact my decision-making here.
Elvire, in Croix-Rousse Hospital, we use a lot telos.
Alors, on ne fait plus du tout de telos parce qu'une fois sur deux, ils sont très mal faits.
Ceux-là sont bien faits, hein?
Non, ils sont bien faits. Mais donc, j'en fais plus, c'était trop mauvais. Mais, par contre, c'est vrai que la différentielle, alors là, il y a 4 mm, mais t'avais un arrêt dur retardé, si j'ai bien compris, c'est ça? Est-ce que tu as fait ça en pensant, finalement, la greffe, j'ai pas encore l'IRM, la greffe est là, mais elle est pas fonctionnelle, et tu pourrais faire juste, finalement, une plastie antirelatérale?
On va discuter ça après. Tu vas voir l'IRM.
Ah pardon, mais tu vois, voilà, il y a la question.
Oui, l'arrêt dur est bien ferme. Il y a effectivement un ressaut que vous avez vu qui est pas monstrueux. Et le télos montre que 4 mm d'écart, ce qui est pas énorme en soi.
Mais les télos, on les fait plus. Par contre, on a fait beaucoup de GNRB. On avait un thésard qui a fait là-dessus et on a arrêté aussi. Donc aujourd'hui, la laxité, je l'évalue, je dirais manuellement, mais plus avec un outil.
Cette question, elle est plus large en fait. Elle est comment on documente un patient et comment on peut le mettre dans des catégories. Alors on peut dire oui, c'est un croisé et tout le monde traite un croisé, mais c'est comme ça que on arrive à dire c'est bien de faire une plastie extra-articulaire là, c'est bien de faire une ostéotomie là, c'est bien de dire peut-être que là il va y avoir des ménisques abîmés. C'est comment documenter un patient, quelle que soit sa pathologie. Et moi je pense que c'est vraiment important d'avoir un moyen, télos, GNRB, rollimeter, whatever, mais c'est important.
Et en parlant de documentation, il y a un élément qui manque, bien qu'a priori on puisse penser qu'il n'y a rien, c'est le ménisque. Parce qu'effectivement, si le ménisque est abîmé, par exemple, pour ce type de choses, on aura peut-être tendance à faire une ostéotomie de déflexion, à utiliser une allogreffe un petit peu plus rigide. Et je pense que ça fait partie aussi de même si on peut penser que vu ce qu'on voit, le ménisque est plus ou moins indemne, mais je pense que s'il a un problème, il faudra peut-être l'intégrer dans la stratégie.
Tiens, tu peux regarder le ménisque sur l'IRM en direct. Bien sûr que si, c'est la même patiente. Qu'est-ce que tu insinues? Si, il y a eu
Donc il n'y a pas de lésion méniscale.
J'ai le profil de la même patiente. Les vues sagittales.
Il n'y a pas de lésion méniscale.
Belle greffe bien verticale.
Il y a une greffe qui a l'air bien présente, hein. Elle a l'air normale. Non?
Any of the experts would propose a isolated extra-articular reconstruction for her? Camilo?
Je reviens juste une seconde sur les radios. Il n'y a pas de lésion méniscale. Le croisé semble être un petit peu comme une rupture partielle. Et ben sur les radios, on peut déjà imaginer que on va voir ça à l'IRM. C'est en ça que la documentation est intéressante.
Parle dans le micro.
No, for this case, if we check the arthroscopy and the graft is intact and it's functional, and if there is less than 5 millimeters of translation and no more than 1 grade pivot under anesthesia, and it's a low risk patient, we consider isolated extra-articular tenodesis. However, this patient, he has like hyperlaxity, and it's a high-risk patient, 20 years old, so I would not propose isolated extra-articular tenodesis for this case. However, it's possible to do in selected cases.
Alan?
For me, this question really comes down to what you think the mechanism of action is of your lateral tenodesis. And I really don't know. You know, we can do cadaveric studies and we know that it has a primary role in controlling anterolateral rotation when you add it in the cadaver. If you look at Volker's studies, you know, over time, you know, on their treadmill and using biplanar fluoroscopy, it would appear that the lateral procedure stretches out and has less constraint from 6 months to 12 months. So yes, we showed in our trials that and you've shown in your studies that the lateral procedures reduce graft failure. But, you know, I don't know if that's because it's controlling anterolateral rotation or if it's just stress shielding your graft as it heals, potentially even slowing down rehabilitation. There's multiple different ways why it could be working. So for me to do a primary tenodesis to address this problem, I'm not sure it's going to work in the long term. So I want to combine it with a revision ACL reconstruction, a reconstruction that's done well with a good graft, and I think that's the best way that I can control her and I'm putting her through an operation and a rehab. I basically want to look her in the eye and say I did the best possible operation for her.
Do you consider something on the posterior capsule when you have hyperextension, like 15 degrees, 20 degrees? Because Professor Judet described a procedure to tightening the posterior capsule, and we did some case on Cross.
Comment est son point d'angle postéro-externe cliniquement? Elle a une laxité postéro-externe ou pas?
Non, c'est un peu global.
C'est un peu global.
C'est pas.
Parce que la question qu'on peut se poser sur ce genre de cas, c'est de se dire on a une greffe, finalement on a une instabilité qui est assez périphérique et on pourrait travailler que sur la périphérie.
JC, would you do an isolated extra-articular reconstruction?
Do you mean an extra-articular tenodesis?
Isolated.
Well, if the patient was 50 years old, probably yes, but at 20 years old, of course not. What I could consider if leaving this ACL as it is, if there is no interference with the new correct ACL, and then build a new one, a good ACL graft, or just take it all, because if there is interference at the femoral side, not the tibial side, of course I will like to have a good ACL attachment. So either way, if it's no interference with this graft, I will build another graft beside it. If it's any interference on the femoral side, I will take it all and fill up the tibial tunnel, fill up the femoral tunnel, and at the same time do the new ACL, probably bone patellar tendon or quad tendon, autograft. Because concerning the allografts, it is always my opinion, because it has been, I have a huge experience in the past using allografts, that the allograft, of course, is new collagen at moment zero. But over time, this collagen should be maintained by the cells. And the cells come from the same individual. And the individual has this condition of hyperlaxity. So over time, probably the allograft will be the same that the autograft. So that's a bit of concern for me. But yes, autograft, either PTB or a quad tendon and an extra-articular tenodesis.
Bob? What will you do?
Would you use allograft, Bob?
Would I do an allograft for this patient? Yeah. No, in this revision setting, in a young active patient, I would do a patellar tendon autograft. To get back to the other question about the isolated lateral procedure in this patient, I would not go for it, similar to the reasons that others have outlined. I think I think it's important to remember when we're talking about adding a lateral procedure that's obviously becoming more and more in vogue, but we have to remember that we're only doing this in the setting of a relatively normal intra-articular reconstruction. And I really think we don't have that here. We have, on that Lockman, we had some substantially increased translation. And even though the TLS is only 4 millimeters different, I still think if you are proposing that the too much work for the lateral procedure to do in this case, even especially in a young active patient. So I would not do an allograft for sure. And in this situation, I would not do an isolated lateral procedure.
David?
Cette greffe est présente, mais elle ne fonctionne pas, donc évidemment qu'il faut faire quelque chose. Et il y a une indication de reprendre la plastie intra-articulaire. Et compte tenu du contexte, évidemment, il faut ajouter une plastie extra-articulaire, et elle va aller parfaitement bien, à mon avis.
Elvire, tu ferais la même chose?
Oui, je ferais la même chose. J'ai l'habitude de demander toujours le compte-rendu opératoire, essayer de récupérer le compte-rendu opératoire. Et je crois que malgré tout, je ferais non pas une plastie antérale, mais une ténodèse extra-articulaire, parce qu'à chaque fois, les patients qui ont eu même ou un DIDT ou un DT3 ou un DT4, en général, le gracilis, il est parti à la poubelle, on le retrouve pas. Donc, méfiance. Enfin, voilà, c'est pour l'auditoire, quelquefois, faites attention, parce que même si c'est dans le contrôle opératoire, quelquefois, le gracilis, il est plus là, il vaut mieux déjà prévenir le patient, parce que c'est quand même pas la même cicatrice quand on fait donc je ferais un BTB sans doute, et puis avec une ténodèse extra-articulaire.
Oui, là, c'était DIDT, on avait le compte-rendu opératoire, et
ouais.
Après, parfois, on peut peut-être le voir sur l'IRM, mais c'est pas si simple que ça, s'il reste le gracilis. Mais... D'autres commentaires? Ouais, Stéphane?
Moi, je vais vous provoquer un peu, mais j'aurais presque tendance à laisser le ligament en place, à faire une allogreffe en passant over the top et à se servir de l'allogreffe pour faire l'effet ténodèse.
Donc une augmentation.
J'aurais fait une augmentation et j'aurais fait un geste externe à type de l'équivalent en me servant de l'allogreffe.
Oui, mais ça c'est pour faire marcher ton association.
Le problème c'est que c'est pour le bien de tous.
Ah, si c'est pour le bien de tous. Amen.
Bob, last comment.
I just worry in a situation like this where you have a pretty big intra-articular graft already, and then you add an extra-articular allograft. I'm a little worried about overstuffing the notch in this situation, so I think that would be a concern.
Elvire, 30 secondes.
Oui, je vais rajouter une petite chose, ça va faire plaisir à Bertrand, mais je pense que ces cas-là, c'est vraiment facile à réviser quand on fait de la hautine.
C'est vrai. Merci à tous et aux orateurs. Superbe session. Merci Bertrand.